And our next speaker is Dr. Meijer. And it'll be no surprise, he's going to talk to us about the work he's very passionate about, the work that has changed how we do PCI in the state of Michigan on radiation management, our BMC2 success story, and an update on the new mitigation systems.
All right, thank you, everybody. So these are my disclosures. So just going to start with very briefly risks of working in the cath lab. I think all of you guys know this, but it's a reminder that we are at risk. There are data showing that we are at risk for premature cataracts, premature atherosclerosis, particularly in our carotids. Left-sided brain malignancies may be something that we're at increased risk for. There's evidence that even a single procedure, we can actually measure measurable rises and falls in DNA damage biomarkers in interventional physicians and skin lesions. And so in order to reduce, the risks of wearing lead, and I'm sure there are people in here and certainly colleagues in your cath labs, both physicians and staff that have had their careers shortened by orthopedic injuries and chronic work-related pain. And so really, I think when we think about radiation safety in our cath labs across the state, we got to address both of these things. And so just as a reminder, this kind of air kerma of 5 gray is the dose that we should be thinking about live during our cases. And as you approach that 5 gray dose, you really need to be thinking about an exit strategy on how to end your case. And the reason is this is kind of the poor man's marker of when your patient may be at risk of a skin injury. To really figure out the risk of skin injury, you have to have a physicist calculate the peak skin dose. But again, the air kerma and using that threshold of 5 gray is kind of a poor man's marker for when that risk starts to increase. And we'll keep that in mind as we look at our data across the state. And so I think most of you probably remember we did a deep dive on this a couple of years ago. And so this study that we published in 2020, we looked at the rates of air kerma of 5 gray or higher across all cath labs in the state of Michigan. I should correct that. It was 28 cath labs. So there were 33 hospitals at the time without on-site cardiac surgery in the state. We excluded 5 hospitals among them that did not report air kerma values in their PCIs. And so we were left with a study population of 28 hospitals. And during the study period, looked at 36,000 PCIs across those 28 hospitals. And what we saw, as shown there in red, is that the air kerma dose, on average, about 4% of PCIs at that time had an air kerma of 5 gray or higher. And it was really interesting when you look on the right side of the screen there that over that 21-month period, we had over 100 cases in the state with an air kerma of more than 15 gray. And those are actually sentinel events by the Joint Commission. That's a really big deal to have a dose that high. And I was shocked that in that short time frame, we had over 100 patients with a dose of more than 15. That to me was mind-boggling. But we wanted, to try to improve this. And one of the ways that we, did this was to have all centers kind of take a hard look at where you were relative to other centers in the state. And so you can see that dotted line across the middle. Again, 4%, of hospitals were having air kerma doses of cases. 4% of cases had an air kerma of more than 4 gray. More than 5 gray. And each bar across this figure represents one of the 28 hospitals. And so the numbers you see here, the frequency of PCIs per center that were more than 5 gray air kerma doses. And so it ranged from everywhere from 0% at some hospitals to, almost 11% at a couple of hospitals. And so, this variability that we saw across the state in the frequency of these really high radiation doses, represented an opportunity for improvement. And I think the other thing to think about is not only are getting these doses down important for patients to lower their doses, but remember all of the radiation that you are getting standing there in the cath lab is coming from scatter radiation off of that patient. If you can lower the patient's dose, you will lower your dose. You will also lower the doses to all of your staff members. And so we started to work on this. And so this is just an update. We've looked at this data recently and I wanted to show kind of what we've done. And so this was the timeline of this safety initiative, started in 2017 with, kind of assessing baseline doses. We then did a bunch of just education across the state through BMC squared meetings. We put together a best practice protocol for radiation safety in the cath lab. We had one of the years we had metrics, to kind of drive this. But this was a summary of kind of all the work that we put into this. And one of the things that we recognized in looking at these kind of repeat data to follow these trends that are, if procedural complexity is going up, you would expect that radiation safety or radiation doses would also go up across the state. And so this was looking at markers of procedural complexity over time. And what we saw was that, that procedural complexity actually increased over this 6-year time frame, including increase in left main PCI, mechanical support, and atherectomy. CTOs did not increase over that time frame, but these others did. We were, concerned that might, result in increased doses, but what we found was actually the opposite. So this is over this 6-year time frame, the frequency of PCIs across the state with an error curve of greater than 5 gray. We started at that 4% mark. We've now driven this down to less than 1% of PCIs in the state of Michigan now happen with an error curve of more than 5 gray. And when we looked at this and adjusted for, procedural and patient characteristics, we saw that it decreased by about 7% per year over the 6-year time frame. And so we're really excited about this. Thank you to all of the Cath lab directors in here, who have worked on this at your own institutions. But I think this has had a significant impact. This is just another way of looking at this, breaking the doses down by, ranging between 2 gray and 5 gray, 5 to 10 gray, and greater than or equal to 10 gray. And in each of these categories, we saw doses decrease significantly over this time frame. And then this is just a repeat of that figure that I showed up front across these 28 hospitals. So the dark bars are where we started. The lighter bars are where we are now in the most recent year that we have data. And so you can see there's only one center that actually had an increase in the percent of their PCIs with an error curve of more than 5 gray. Every other center that we tracked actually had a decrease, several of these centers falling really dramatically. We don't quite understand, what ultimately led to these decreases, but I think it's pretty phenomenal that we saw this. And I'll maybe stop there. Any comments from anybody who maybe has worked on this at your institution, what you guys have done to achieve success in this regard?
You hear me now?
Yeah.
So I'll just say, I guess, the usual stuff that you guys taught us, in terms of frames per second and saving flora with the new technology. So we rely on the new technology. But like in our lab, we have 2 labs that are old. You can do that, right? And 3 labs are new. And it's frustrating that the leadership, the administration in the hospital don't recognize the importance of that. And so when we're arguing for, new machine to buy, just based on that, we don't get the response that we're looking forward to, unfortunately. And there's nothing we can do. So in our institution, we avoid now doing cases in those 2 labs because of that. And that's how we're able to get down to less than 1%,
Agree that newer fluoroscopy systems are going to be associated with markedly reduced doses, but there are a lot of, I think, as you alluded to, Eddie, a lot of practical things that you can do in your lab to reduce your doses, cutting your frame rate, using fluorosave when maybe before you would use Cine for everything to capture images. And so there are practical things that can be done. And if that's of interest to you in your lab, please, reach out to me. So, Shadi, you had a comment?
Yeah, can you hear me? Okay. We have the same thing. We were like, I think, the highest in the state in terms of radiation. Unfortunately, we don't have the privilege of getting equipment quickly at the Detroit Medical Center. So what we did is increase awareness, and we review these cases carefully and sending letters to the operators. So eventually we narrowed it down to 2 operators were mainly the culprit, and then we sat down with them and changing practice. And it was all about staging the procedure, about changing the technique, or double scrubbing to help expedite the process. And we noticed some change in pattern, especially with the beginning of the year compared to the end of the year, at the level of the training of the interventional fellows. So we ask them to scrub from the beginning of the case because sometimes they struggle to engage, take that whole lot of radiation before the time comes and the attending kind of engage and proceed with the procedure. It end up to be complex. So these two things, kind of awareness letters, review cases, help us go, significantly down.
Thanks. Any other comments about this?
I think you shared with us sometime data. I can't remember exactly whether there's a difference between programs that have fellows and versus no fellows in terms of.
Yeah, we looked at that. I don't think we saw a difference. I don't know if Hitinder or Raj, if you guys remember, but I think we looked at that and did not see a significant difference. Yeah, good. So, now that we've, reduced doses across the state, and have gotten these doses, I think, to, much better levels, I would like all of you to think about, additional things that you could be doing to protect yourselves, your partners, your staff. And I would argue, you don't want to wait till you have an orthopedic problem. You don't want to wait till you have a cancer in your cath lab, to start thinking about this, because I think too often that's when people start to think about it. And I think you can do a lot more to proactively try to prevent these issues. And so this is just a list of practical tips, as I had mentioned, that you can look at to reduce doses. But what about other things, adjunctive devices, et cetera? This is a relatively simple solution. These kind of, 6 foot tall, leaded shields. These are relatively inexpensive. We studied this at our center several years ago, published this in JACC Interventions, showing that the use of these shields, you put these in front of the nurses or in front of the techs for cases, and their doses are cut by about 2/3. And so we, based on this data, went to the hospital and argued that we want one of these for each of our cath labs. So we now have these standard in our 5 coronary rooms for all of our nurses. We've actually mounted IV poles on them. So the nurses, when they approach the table, the physician is supposed to get off the pedal, but if they can't because it's a STEMI or something else that's urgent, the nurses at least have this level of protection to keep themselves safe. The radiation absorbing pad has been studied, in a randomized controlled trial compared to a sham pad and no pad, and shown to significantly reduce doses. 44% compared to no pad, 20% compared to no pad, 44% compared to sham pad. This is something else that you could be consider using. This does add expense per cases, but there are some ways around that, and be happy to share some practices if this interests anybody. Suspended lead suits. I think this has really been a game changer in our lab. We recognized the benefit of this potentially about 10 years ago. We now have one of these in each of our coronary rooms. Our physicians, our interventionists at our hospital don't wear lead anymore, and I haven't worn lead routinely for procedures in about 10 years. And so this suspended lead, it's got a blast shield that kind of protects your head and neck. The lead that's on there is actually thicker than the lead that you would be able to support with your own body. And so we've studied this in our lab. This was an early study in PCI cases. We saw that it reduced head level exposure by about 97% to the primary operator. And this was a more expanded analysis that we published in CCI in 2021, over 1,000 cases. And you can see the blue bars there are the head level doses for the primary operator using suspended lead. And the yellow bars there are doses using conventional lead. So you can see a 98% reduction in dose across kind of all cases. And after we adjusted for other factors, still seeing about a 94% reduction. And again, not only are we getting, almost eliminating radiation exposure at the head level with these, but remember, all of these cases were not supporting the weight of the lead on our backs, and hopefully there'll be benefits with that long term. So, and then there was a lot of interest when we met, at Cantoro Market for the last meeting on these novel shielding systems. So there are 2 that I'm aware of are on the market. The one on the left is called Protego. The one on the right is called Rampart. I think Henry Ford maybe had a Rampart system. I don't know if they purchased it or were just borrowing it, but there have now been a couple of centers that have tried out this, the Protego system on the left. The goal of these systems, though, is to get everybody in the cath lab out of lead. And so it's this series of shields, the Protego on the left there. You can see these shields that go up and kind of trying to box out the radiation, the scatter radiation that comes off of the patient so that everybody can get out of lead. I did some preclinical testing with Simon Dixon on this with a radiation physicist, and in this kind of preclinical work that we measured, using a phantom that scatters radiation, saw that it reduced doses of kind of around the room anywhere from 97.8% to 99.8%, depending on the location. So fairly good protection. Based on that, interestingly, the state of Michigan did issue this company a letter saying that if anybody uses this system, they don't have to wear lead because this seems to be as good. I wasn't quite ready to jump on that without testing it myself. But these are data that have come out of Beaumont. These were published in CCI earlier this year. They did 112 consecutive cases. There was not a control group. They monitored radiation to the primary operator in real time. They had an interesting approach where they would have the radiation monitor up, the primary operator and the team would be watching that. And if the dose got too high, they would then take this down. Everybody would put lead on. I haven't had a good understanding in what that level was that made them think that all of a sudden, they needed to switch, but that was the approach. So ultimately, they published the data for 98 of these cases that they used this throughout. I understand that the primary operator in these cases did not wear lead. 25% of these were diagnostic, 75% were PCIs, high percentage of CTO cases by this operator in these. And these were the median doses there. You can see at the thyroid level, 0.4 millirem, that translates to about 4 microsieverts. Waist level, 0.2 millirem, or about 2 microsieverts. And I think I'd like you to keep these doses in mind as we look at some of the other studies, that have, control data. But interestingly, there was about 10% of cases where the dose was 0, and in no case did radiation exposure exceed 3.2 millirems. I'm a little less excited about that 3.2 milligrams. That's 32 microsieverts. That, in my opinion, is a little bit high to be getting exposed and not wearing lead. So these are data that David Ryzik just published in JSky. And so this was an observational study, single center, 25 cases with Protego, 25 without. 46% of PCI cases were PCI in the Protego group, 38% PCI in the controls. And you can see here that that at the waist level, green is without Protego, red is with Protego, and then thyroid level, again, green without Protego, red with, and showed significantly reduced doses with use of the Protego. The one thing I don't love the way that that they published this was that the waist controls were outside of the lead. And I think the more appropriate control is you want to know what's getting, underneath the lead. That's the part that you care about, not what your lead is getting. And so nonetheless, and these were the average doses. I think it's more appropriate, given that these data are not normally distributed, to look at median doses. But I think really, something that's really interesting, the median dose at the waist and thyroid level with use of the Protego was 0.0 microsieverts. And so this, I think, does give some, reason to consider this as a hope for the future and getting out of lead, that they were achieving doses of 0 at both those locations. And again, these were in the standard protection group. They were seeing median doses of 54 or 56 microsieverts. I also think that's a little bit high. I would not be happy in our Cath lab if our operators were getting doses, a median dose of over 50 microsieverts per case. And so that's just, it's high for me for control. And then these are data. We did trial this at our center, did 25 cases with, 25 cases without. We are getting this ready for publication, but so you can see here the blue bars represent the median dose in primary operators, scrub technologists, and circulating nurses. The 3 sections on the left are for head level radiation, and then on the right is waist level. And so you can see head level protection. I think this system does a phenomenal job of being associated with very low doses. And so I think it's very good in that. The circulating nurses actually had a dose of 0.0 microsieverts in all cases. I don't think in our lab, if we were to purchase one of these and use it, I would feel very comfortable with our nurses taking off their lead. Scrub technologists had no case where their dose was more than 1 microsievert. And to put that into context, the threshold, annual threshold is 50,000 microsieverts before you have to sit out. And so if you're getting everything less than 1 microsievert, you could conceivably do 50,000 cases a year and still not hit that threshold. You're probably okay to consider taking off lead. And then the primary operator, same thing. We did not have any case with use of this system that the primary operator had a dose of more than 1 microsievert. And so, very low doses at the head level. The one place that I would urge caution, if any of you do use this system or trial it, is at the waist level. And I've seen this at our center. I was in Stockholm, Sweden, doing cases, during the pandemic at a hospital there that was using Rampart, and I encouraged them to put the badge on their waist. They saw the same thing. There tends to be a leak of radiation around the access site with these systems, and that's something that these systems need to continue to work on, where they provide better shielding so that you don't have that leak. I would argue that's not a location that many of us would, welcome radiation as at our waist or groin level, but there's a leak there. And so you can see that there under the primary operator, where the dose was actually higher with use of the system compared to without. The dose without, when you're wearing lead, we monitored under our lead, the dose is 0.0 microsieverts in all of these. I will say that these were majority diagnostic cases, simple cases, but still the system, I think, performed reasonably well. And then this was just cumulative doses over 25 cases. So you can see how this really adds up over time when you're, being exposed to radiation. And so again, standard protection, head level, these doses really add up over time. So last thing I'll talk about is just robotic PCI very briefly. You can perform this from the cockpit, or nowadays you can have controls put into your control room. The dose in these when you're doing these is 0 if you're staying in the cockpit. The studies that have looked at this measured radiation, if they're done with diagnostic cases, you're going to get some exposure in the diagnostic cases. If you stand up during the case and get exposed, you're going to obviously get exposure that you wouldn't have sitting in the safety of the cockpit. This I'll skip over. And so I'll just finish with this. I think you are all familiar with this concept of ALARA. We're trying to get doses as low as reasonably achievable. And I think one thing I'd love for you guys to leave, today with thinking about is what is reasonably achievable 10 years ago? Is that still what's considered reasonably achievable now? And I would argue probably not. The median doses with these devices I've put, in here are, all under a microsievert of exposure at the head level compared to, you can see the controls there, more than 10-fold higher without. And, given that a single case with about 15 microsieverts, we can draw blood before your case starts and after it's done and show that you have a rise and fall in DNA damage biomarkers within your own body after a single case of 15 microsieverts. I think, it really should give us pause about, what we're exposing ourselves to. And hopefully we can, convince hospital administrations to help protect us and make our environment safer for working. Thanks.